And we're live. Good morning, good afternoon, good evening. I'm delighted to welcome all of you to the next in the seminar series for the Lancet Commission on Gender and Global Health. And it gives me huge pleasure to introduce Dr. Morna Cornell, who will be talking about a topic that I know is close to many of our hearts. Dr. Cornell is from the School of Public Health at the University of Cape Town. And without any further ado, I'm simply going to hand over to you, Morna, to talk to us about men and gender and global health. Thank you, Morna.
Sorry. Well, of course, immediately my presentation has disappeared. If you hold on 1 second, I will find it again. There we go. Right. Thanks for the chance to talk to you today about what I regard as the elephant in the room of gender and global health, the neglect of men in the response to HIV and in public health more broadly. In this series, a number of people have spoken about the need to hear other voices, and in many ways, I think I speak with a different voice. Unlike most of the commissioners, I have no formal background in gender studies or in global health. My own background is in human rights activism and subsequently in public health research. And I had a very late entry into academia, starting my tertiary studies for the first time in my mid-40s. But being an outsider can be helpful in bringing a different view, and perhaps in being a bit disruptive, as we've been asked to be in this commission. And so I'd like to talk from my own experience about how I came to see men as the elephant in the room. I'd like to start by describing my context. I live and work in the global south in sub-Saharan Africa, which is the epicenter of the HIV epidemic, and home to 2/3 of all people living with HIV. South Africa is defined as an upper middle income country, but it is also possibly the most unequal country in the world. About half of our population live below the poverty line, about 1/3 are officially unemployed, and this includes about half of all youths aged 15 to 24. My own home is in Cape Town. It's been voted one of the most beautiful cities in the world, but it has two very different faces depending on your social position. On the left, a squatter township with the iconic Table Mountain in the background, and on the right, a mansion nestling on the slopes of the same mountain. South Africa has overlapping epidemics of poverty and inequality. We have the largest number of people living with HIV worldwide and an extremely heavy burden of TB and co-infection with HIV. We also have endemic rates of unnatural deaths, increasing rates of NCDs, and of course, an uncontrolled and largely unvaccinated COVID epidemic. And once again, in South Africa, political upheaval threatening our health system. And all of these impact on huge numbers of largely poor people and are highly gendered in exposures and outcomes, yet these are poorly understood. Between 1992 and 2000, I ran something called the AIDS Consortium. And this was a national network of individuals and organizations fighting for the rights of people living with HIV. This was at a time when people with HIV had no guaranteed rights, and levels of stigma and discrimination were incredibly high. It was a time when HIV was literally a death sentence because we had no treatment. And underlying our work was the fear that everyone we knew with HIV would die, and far too many did. It was also a time when HIV was regarded by many as a white disease, a gay disease, because, I quote, homosexuality is not in our culture. The AIDS Consortium was an extremely broad coalition. We came with very different priorities, but we all agreed that people living with HIV were entitled to human rights, and we organized around that. We defined these rights in an AIDS and HIV charter and used this as a powerful advocacy tool. And partly as a result of such advocacy, South Africa has arguably the most progressive constitution in the world, which entitles people living with HIV and their families to full and equal enjoyment of all rights and freedoms. But of course, realization of these rights needs advocacy because it costs money and raises questions about who deserves care, who is valued in a society. So in the early years, babies and women were described as innocent victims and thus deserving. And so in the 90s, our first fight for treatment was for AZT to prevent HIV transmission to babies. and then for dual therapy to keep the mothers alive. Then in 1996, I was at the AIDS conference in Vancouver, which entirely changed the landscape. There was the groundbreaking announcement that triple therapy could stop the virus from replicating, and suddenly there was a possibility of life, if you could afford it. In 1998, I went to the Global AIDS Conference in Geneva, and this conference had the catchy and totally untrue title of Bridging the Gap. It was supposedly aiming to bridge the gap of treatment between richer and poorer nations. And this quote from a Lancet editorial at the time noted that the big debate will center on equity in treatment access. Does this ring any bells in the time of COVID? I returned home with very mixed feelings, excited about hearing about the Lazarus effect, which was treatment activists from the North describing their recovery on treatment. But for many of us, what became clear and increasingly clear was the massive and widening gap between the global North and the South. And as Ray once said, we are a data mine. The North has many publications. The South has the large populations under study. And we felt a growing rage at the uncrossable divide between those who could and could not pay for life, and the fact that some lives seemed to matter more than others. This anger gave rise to social justice movements and treatment activism with legal and illegal protests, and people living with HIV putting their bodies on the line in clinical trials without guaranteed post-trial access. Again, does this ring any bells? This activism helped to reduce the cost of triple therapy to an affordable generic combination within a few years. And please remember, the drug companies were still making huge profits. All of this took place against the backdrop of high-level government opposition in South Africa, from a Minister of Health who resisted giving AZT to prevent HIV transmission to children, to babies, to a president who denied a causal link between HIV and AIDS, and a health minister offering beetroot and garlic as alternatives to antiretroviral therapy. But eventually in 2004, kicking and screaming, South Africa started its antiretroviral rollout, and today we have the largest program worldwide with over 5 million people on treatment in 2019, a remarkable achievement, particularly in our context. Meanwhile, in 2002, I co-authored a book on our explosive HIV epidemic. And from 90 diverse conference papers, the major thread I concluded was what it means to be a man or a woman in Southern Africa, and how this understanding impacts on HIV risks, suggesting that our epidemic may be more about gender than biological differences. South Africa also has an excellent record of clinical research, and from 2002 to 2007, I worked in HIV research in a program called CIPRA SA, which is a huge multi-site program. And we were looking at ways to try and implement public sector antiretrovirals in situations of limited resources. This study here provided crucial evidence that nurses could deliver treatment, supporting task shifting in situations such as ours. Another study was the groundbreaking SURE trial among HIV-positive babies, where we found that immediate treatment reduced early mortality and HIV progression by 75% and changed global pediatric HIV guidelines. Working in clinical research triggered an interest in the science underlying HIV treatment. Excuse me. And so in 2005, I started tertiary studies for the first time, 30 years after leaving school and having never done any undergraduate degree. I specialized in epidemiology and biostats, and I learned about the value of good evidence. Building on my earlier interest, I did my master's thesis on gender and survival and treatment, and I found that men had higher mortality than women. And my literature review confirmed the prevailing wisdom, which anecdotally blamed men for their own poorer outcomes, along the lines of, oh, you know what men are like. They won't go to the doctor. When they do, they're older and sicker. They don't take treatment, and they're more likely not to stay in a program. But having learned about good evidence, I was uncomfortable reading these generalizations repeated as evidence. And so in 2012, in one of my PhD papers, I tested these explanations in a much larger study of over 46,000 people living with HIV. And I found that men had far poorer access to treatment. They comprised only 30% of those starting treatment. And in a later analysis, I can tell you that this proportion did not increase 1% over 12 successive years of enrollment. And they had higher mortality than women did. Considering the explanations in the literature, men being older and sicker when they started treatment explains some, but not all of their excess mortality. And we had no evidence that men were less adherent, more likely to die after being lost to care, and biological responses were similar by gender. So I really wrangled with why mortality was higher in men. And then I had my aha moment. And I thought, I wonder if there's a gender difference in HIV negative mortality. And so with Lee Johnson, one of my co-authors, I compared mortality in antiretroviral patients with HIV negative individuals. And amazingly, we found that not only was there a mortality difference, it was far greater in the HIV negative group. Being in HIV care seemed to protect men on treatment against some other health risks. And over time on antiretrovirals, the deaths seemed less and less likely to be related to HIV or ART, but more to reflect the background risks. And in South Africa, much of this additional risk is due to violence, road traffic accidents, and suicides. Since then, I've seen increasing evidence of gender inequity in HIV programs across sub-Saharan Africa. Women have higher incidence and have thus been prioritized appropriately for targeted funding and programming. They also have better access to treatment than men, and they have far lower mortality. In contrast, men are much less likely to be tested and to start treatment. They're sicker and older when they do, and they have a higher risk of death. But all of this is only evident when you disaggregate. The WHO explains the critical importance of disaggregating systems for health systems, disaggregating data for health systems that lets you identify gender inequities and respond to them appropriately, and also, importantly, allocate appropriate resources. It's great. But if it really is so critical, why did the WHO only start reporting disaggregated global health stats for the first time in 2019? How would resources have been allocated appropriately without this information? UNAIDS set ambitious 1990-90 targets to end AIDS by 2030, and these required that by 2020, 90% of all people with HIV would know their status. Of these, 90% would be on treatment, and of these, 90% would be virally suppressed. Without exception, men have done worse in all the 1990s across sub-Saharan Africa consistently over all of the years of reporting. So the regional reporting from West and Central Africa, for example, shows clearly how an overall estimate masks important differences between men and women. And indeed, the largest single gap in HIV services in sub-Saharan Africa is testing, where over 700,000 men aged 35 to 49 did not know their status in 2019. So much of the rhetoric about equity in health sounds good. You have your SDGs, you have your SDG agenda, the WHO. Why then has there been so little response to such a huge signal of gender inequity in health? It doesn't make sense to me on the grounds of human rights or on public health. And then I found that this neglect wasn't restricted to HIV. It was also evident in many other health conditions. And since the first ever reports, TB incidence, prevalence, and mortality have been higher in men, yet TB programs have continued to focus on women and children. So much so that it has been called a systematic neglect, which reinforces gender inequalities. I also found that this neglect was not limited to low and middle income countries. The Lancet, you will know, produces the Global Burden of Disease Studies, which combines data from over 200 countries around the world. And its explicit intention is to help set funding and programming priorities. Yet it did not report disaggregated statistics. And in 2013, Sarah Hawkes and Kent Butte reanalyzed the disaggregated burden of disease stats, and they found that men had a higher burden of disease and lower life expectancy than women. And again, this raises the question, how were appropriate priorities then set if they did not have this information? Scientific journals must also share responsibility for how studies are reported. In the Lancet Burden of Disease study of global TB, men comprised 2/3 of all the HIV negative incident cases and death, and over half of the HIV positives. Yet these critical findings were absent from the summary, from the research in context panel, and the discussion, none of which even mentions that being male was a major risk factor for TB. Research that ignores gender inequities helps to perpetuate them. And in a recent example, the UN General Assembly issued a 19-page declaration to end inequalities and end AIDS by 2030. It notes that sub-Saharan Africa remains the worst affected region globally, and that men have poorer outcomes than women across the HIV testing and treatment cascade, yet it only calls for action to curb the effects of the epidemic on women, adolescent girls, and children. Violence is a major cause of injury and premature mortality, particularly in sub-Saharan Africa, and is highly gendered. In South Africa, we have horrendous endemic levels of violence against women, particularly sexual and intimate partner violence. What is less well known is the equally horrendous rates of violence against men. Globally, men have got 3 times higher rates of death from interpersonal violence than women do. South African women have got 5 times the global risk of death from violence. South African men have 6 times the global risk and 5 times the mortality risk of South African women. Yet in 2014, the WHO and the World Health Assembly issued a resolution to strengthen health systems to prevent violence, specifically focusing on women and children again. And this set a new precedent, directing prevention efforts away from the most vulnerable group, and again raising questions about who we regard as deserving of care. If we want to be truly disruptive, as we have been asked to be, we could discuss whether most violence isn't gender-based, given that it emanates from systemic toxic masculinity and that men are also the victims of such violence. And I believe that we should be considering including violence as the overarching structural issue that has a huge impact on health and in which violence towards women is a critical element. So this is why I see men as the elephant in the gender and global health room, this growing body of evidence, good evidence documenting men's poorer access and outcomes in healthcare, but global and national policies and responses that specifically target women. I've spent a lot of time thinking about why this is. And I don't believe there's been a conscious desire to exclude men. And certainly the early gender focus on women's health was appropriate, given patriarchal power dynamics. But I think that too often gender is still conflated with women, even in discussions that we have in this commission. And I think that gender and health are still seen as a zero-sum game, in which men and women are competing populations and men are somehow less deserving. In 30 years of working in HIV, I have never heard anyone speaking about women's health first disclaim that they don't intend to undermine any gains or funding for men's health. Yet I hear the converse every single time anyone speaks about men's health. The language we use is critical. And when gender is regularly conflated with women, it doesn't seem odd to see, for example, these titles or global goals. But once you are aware of this bias, you notice it everywhere. So I challenge you the next time you see the word gender, how soon do you see the word women? And this also obviously reinforces the gender binary and risks excluding trans and non-binary people. So to be further disruptive, I would like to raise the issue of implicit bias, which has been defined as a bias that is present, but not consciously held or recognized. I believe that implicit bias can explain part of the gap between the evidence on men's health and the lack of action. A sense somehow that men are less deserving of care than women, and that men are individually responsible for their own poorer health outcomes. And it also seems difficult to accept that men are vulnerable. Because as Pascal has pointed out, a female bias in gender research constrains debate and limits our opportunities to intervene effectively. And possibly it may even provide some explanation for the limited success to date in mainstreaming gender and health. Historically, and in many situations, men have greater social power and privilege than women, but men are not homogeneous and all-powerful. And this conceptual framework shows how men, like women, are born with sex and immersed into the gender system, and their gendered pathways to health or ill health are influenced by their race, sex, class, age, and ability. And as Raywin pointed out, we also need to consider the impact of colonialism on marginalized populations, including indigenous men. And I would add the impact of apartheid in Southern Africa with its appalling migrant labor system, which tore families apart and disempowered hundreds of thousands of African men. So, for example, this recent blog highlights the intersectional nature of COVID, pointing out that men from marginalized groups, and I'd add disability to this group list, are not necessarily privileged in health and may face higher morbidity and mortality than women. And finally, while there should be space for all of our issues, as we're talking about global health, I believe we must also consider the scale of issues. And that's where my interest lies. Issues that impact on large numbers of people, particularly those who live in extremely unequal societies, where making a difference can impact on many lives. We're all committed to the notion of universal health coverage, but to get there, I believe we need a paradigm shift. And I hope this commission can trigger such a shift. We can no longer, at best, consider men's health an optional add-on, provided it does not take energy or funding away from the health of women and children, on the basis of men's rights, but also on the basis of effective public health responses. I hope that in this commission and in our report, we can highlight the historical neglect of men's health, checked for implicit bias in ourselves, but also in the policies and websites of the international health agencies, major donors, and national programs. I hope that we can use an intersectional lens that is context specific and that we ensure that we do not perpetuate outdated thinking about gender. Since 1992, my journey has taken me from human rights activism to public health research and advocacy. And I believe that all these elements are necessary for change to happen. Others have said that change is not easy, and I agree. But with millions of people worldwide living healthy lives on antiretrovirals, my life has shown me that change is possible. But first, we must see the elephant. I would like to acknowledge those who died without treatment, those who fought for treatment, and those who continue to provide treatment under extremely difficult circumstances. Thank you, Richard, for your slides, 51 to 53. Thank you to my funders, and thank you for your attention.
Morna, thank you so much for raising some critically important issues that you know as well as I are not frequently raised within global health settings. I just want to start with a question to you. And I mean, I think it sort of builds on what you were talking about in the last few slides, but it reflects back on some of the work that was done in the previous Lancet series by Yusra Shawa and Jeremy Schiffman, trying to explain the politics of gender and health. And I'm going to paraphrase a bit, but really noting that one of the challenges in seeing a more gendered health response or gender taken more seriously in health policies and programs around the world is that there is a very, very small community of people working on gender and health. There is a very much larger community of people working on women's health, and possibly an even smaller community of people working on men's health. So the question really is, how do we bring those communities together? What's the one thing that is actually going to bind us all together to move forward together to the benefit of everybody's health?
Well, not a small question, Sarah, thank you. I don't know what the one thing is, to be honest. And I think if we knew the one thing, we probably wouldn't be having these discussions today. What I do find hopeful, and I cited that towards the end of my presentation, was that intersectional lens that was used with COVID, with an alliance between a number of organizations working in men's health and a number of organizations working in women's health, saying the response to COVID should not be gender blind, but it should also not be a gender battle. And to be honest, that's kind of what I feel like. I had some nervousness about obviously always presenting these issues, because it can be very polarizing, and because obviously people are very defensive about the women's health space because of historical reasons, understandable. But I think if we're going to go forward, we really have to be looking at ways, instead of it being posed one or the other. I think that to see these as competing populations, that's why I say I think we need a paradigm shift. And I'm hoping that maybe more and more the organizations working in women's health and men's health understand that actually it's more of the issues of gender and health, and that there is much more of a kind of synchronism about what they do.
Thanks, Morna. So there's a couple of questions coming in from people who are joining us on the live stream, and I'd encourage everybody else who's joining us on the live stream to please post your questions now. So let me start with the first question. Is I think the practicalities, the kind of, so what do we do about it? Work on a men's health strategy in South Africa. Is there such a strategy? Is one underway? We know that globally there's very few strategies on men's health. What about South Africa?
South Africa has very recently come out with the men's health strategy. I'm not entirely persuaded by it. I think there's some quite big gaps in it. I think it's good that it's happening. And I think, unfortunately, what happens often in these situations is that there's good intent and good commitment, but the skills to actually understand the issue are not there, and so perhaps what is produced is not entirely useful. So I would say that we have a very recently produced men's health strategy. I don't think it's a great example, to be honest. I think that there are better examples, for example, from Ireland, and I think Australia also has a good one. Certainly, I think it's a very good step forward is to start to think about men's health. What I obviously would ultimately like to see is that thinking about people's health.
Absolutely. I mean, just as a point of information, we know that there's also a men's health strategy in Brazil and Iran.
Namibia also has one. So there are a few. There are a few, and I think it's a very good starting point, at least.
Exactly. I've got another question, which I suspect it's a very brief question, but I think it probably speaks to a much broader topic. And it says, can we move our focus away from gender-based violence and onto violence? Which sounds very like you'd be able to answer that question with one word. But I think we know that I suspect that what this is a question of is, how do we shift the dialogue and discourse away from the notion that violence means violence against women?
So I think a starting point is to see the elephant. If you do not collect the data and if you do not disaggregate the data, you do not know that this is an issue. And most people that I've spoken to about this, that's why I say I don't think it's a conscious desire to exclude men. I think it's kind of just a bias that we've all internalized, actually. A lot of us have internalized, we don't see it. But I think that once one starts to become aware of it, it starts to become less, you can't really continue it once you see that.
So Morna, I think there's a couple more questions. One is, and I think you've touched on this a bit in your talk, but it'd be great to hear a little bit more about your thoughts on this. Masculinities are key to men's health, but they're also illness, but they're also key to women's illness and ill health. How do we use that lens of masculinities to highlight everyone benefits if we shift masculine norms?
I think it's I think the area, first of all, let me just say, as I said at the very beginning, I'm not an expert on gender and I'm not an expert on global health. That's not my discipline that I come into, but obviously I've become more and more aware of this, and also because it's been cited as almost a kind of a cheap explanation. It's toxic masculinity. It's masculinity, actually, rather than masculinities. I think something that I've become increasingly aware of in the last few years, and particularly through immersion in these seminars, is the notion that it's not masculinity, but masculinities, and that these can manifest very differently in many different places. There's really interesting work being done in South Africa and probably in other places, but certainly on a range of African masculinities rather than individual masculinity. And I think there's a lot of really good work that's been done that could be brought into this commission to inform it. I wouldn't like to be the person who says that, because that's not mine, but I know a lot of people are doing really solid work on this, which I think does bring interesting questions in here. Again, at any point to talk about femininities might be useful as well. So we start to look at it on those sides, because these things are not created individually. We know that.
Indeed, and certainly for everybody watching on live stream, I'd very much encourage people to look at the work of some of the other commissioners who do work specifically on masculinities, both in India and more widely. Okay, just in the interest of time, I'm going to combine the last two questions. So the female-focused programs to which you refer already so entrenched, who do you need to bring together to influence the paradigm shift that you're talking about? I mean, and related to that is the question of what's the potential for men's and women's health organizations to work together? I mean, I know that you've touched on some of this, but it is that core question of how is it going to happen, Morna?
Okay, so the first thing I think is incredibly important is that so much of this, I believe, gets set by the language that is used in the international health agencies, in the donors. You see it in documents, you then see it repeated in national programs, and you then hear people on the ground repeating the same language. So to be honest, I think, and it's one of the key roles I think this commission could do, is to have a look at the language that is used in the websites and the policies of the big international health agencies and the donors. What I was trying to show in my presentation is that I think for change to happen, there's a whole lot of different things that need to happen. I think that is critical, absolutely critical. I think that essentially, if we could also in this commission suggest the need for a real paradigm shift, where instead of it being women's health and men's health as an add-on, we're actually now looking at women's and men's health as a gendered issue, as a properly gendered issue. I think that would be incredibly useful, but I think that's going to be slow and it will take time. But I really do think that examining the language and starting to actually address some of those issues in the terminology and the language that is used at the highest level has a massive knock-on effect and starts to change what is possible in these debates.
Morna, I promised that was the last question, but actually just the very last question has crept in, which I think is highly relevant to what you've just said, which is, how do we shift the language beyond the binary?
Well, I would love somebody who knew a bit more about that than me to talk about that. I think that's I think it's a really interesting question. For me, I'm kind of stuck at least just trying to get men into the discussion, but I absolutely agree with you. There's a whole range of other agendas that we actually also, it would be useful to consider. And I hope that one of the gender experts can advise us on this.
That's a great place to stop, Morna. Thank you very, very much for a fantastic presentation and for answering those questions that I see Emma has noted a flooding in. So perhaps we can come back to some of those later, but really that was a fantastic presentation. Thank you very much. And thanks to everybody for watching and for participating through your questions. And we very much look forward to seeing you at the next